This is a video on internal medicine perspectives for emergency medicine physicians and residents. And in this video, I hope to include a lot of useful pearls and tips that might change your practice. So tip number one is do not obtain stool guaiac testing for the evaluation of acute upper GI bleed. This is because this test has only been validated for outpatient colorectal screening. It has never been validated for screening for upper GI bleed. And it has an extremely high false positive rate. Basically, anything that you can think of can cause this test to be positive. For example, the digital rectal exam itself, eating broccoli, red meat, and all sorts of things can cause a false positive. And most importantly, it does not change management. So clinically significant acute upper GI bleeds will have melena, hematemesis, or brisk hematochezia, not just occult bleeding, and GI will never base their decision to scope based on guaiac testing. So this is even listed in the American College of Emergency Physicians. It's time to abandon fecal occult blood testing in the emergency department. The typical collection procedure for outpatient cancer screening actually involves using 3 separate cards from 6 different stool samples to actually assess for bleeding. The list of sources of false positive guaiac tests is extensive. For example, non-gastrointestinal bleeding from epistaxis or many different foods such as meats and broccoli. And generally, when outpatient screening is being done for colon cancer, patients are instructed to abstain from such foods, which is not an option in the emergency department. FOBT is designed to detect blood from an occult lower intestinal source rather than a clinically important upper GI bleeding. Understandably, as we are using this test outside its defined scope, we have little data with which to accurately describe its sensitivity and specificity. In response, several hospitals have specifically removed the test either from use in the emergency department or the entire hospital. What should you end up doing though if you still have that older attending who says, I want to have that guaiac test? Well, in this case, you can respond, it's whack to guaiac. This is a campaign that was done at the University of Massachusetts. They go over what is fecal occult blood testing, why you might think fecal occult blood test is helpful for evaluation of GI bleed, why FOBT is not appropriate for GI bleed or anemia evaluation. What you should do instead is obtain a thorough history physical exam and actually examine the stool for actual melena, which has a likelihood ratio of 25, or self-reported black and tarry stool. So in the setting of decreased hemoglobin, check for any clinical signs of bleeding and check for an elevated BUN, and use your clinical judgment to determine when to call GI rather than relying on guaiac testing. I want to talk about identifying true melena. So many times patients will say to you that I've been having dark stools when you ask them if they've had any black stools. And really what you need to know is that melena is pretty distinctive. So it is clearly black and it is described as tarry and sticky. So if somebody's just having darker stools, that's actually very non-specific because it's pretty obvious when it's a black stool. Now, what if a patient has black stools and constipation? Well, in this case, you can consider if it could be due to iron supplementation, which can cause stools to become black and tends to have a side effect of constipation. The next kind of lower yield test I want to address is do not obtain ammonia levels in the workup of altered mental status. So there's this Choosing Wisely campaign where each specialty put out various recommendations, and hepatology put on their number 1 recommendation is don't order serum ammonia to diagnose or manage hepatic encephalopathy. You can see this was also published in the Choosing Wisely campaign for the United States by the Mayo Clinic that states that since the 1930s, ammonia has been identified as the principal culprit in hepatic encephalopathy. Many physicians utilize serum ammonia to diagnose, assess severity, and determine the resolution of hepatic encephalopathy in patients with chronic liver disease, despite research showing that ammonia levels are unhelpful in all of these clinical circumstances. Hepatic encephalopathy in patients with chronic liver disease is a clinical diagnosis of exclusion that should not be based on ammonia levels. So a couple of things that they talked about in this paper is that it costs up to $139 per test, and over 5 years cost $2.3 million in a large Midwestern hospital system. And while that may not be that much in the grand scheme of healthcare expenditures, for a test that really doesn't add any clinical benefit or utility, that actually is a very, basically an unnecessary expenditure. Many things can falsely elevate ammonia. For example, if the patient clenches their fist, if a tourniquet was used when it was drawn, and time to processing of the specimen. So ammonia specimens are supposed to be centrifuged within 15 minutes, and it has to remain on ice the entire time. If this is not done correctly, then the RBCs in the sample itself can start to release ammonia. And also, patients are technically supposed to be fasting for this test. The sensitivity is only 47.2% with a specificity of 78.3%. You can compare this to the sensitivity of D-dimer for DVT and PE, which is 96 to 100%, which is why it's such a useful test for ruling out patients with low risk of PE. There are multiple studies that were done that shows that ammonia levels did not impact management in terms of lactulose prescribed or clinical outcomes. 60% of patients with grade 3 hepatic encephalopathy, which is pretty severe hepatic encephalopathy, had normal ammonia, whereas 59% of patients with no hepatic encephalopathy actually had abnormal ammonia. And then 29% of patients actually were found to have higher ammonia 48 hours after resolution of neurologic symptoms. So this also goes to show why there's no utility in trending ammonia. So in general, the conclusion is that patients with normal ammonia can have hepatic encephalopathy, and patients with elevated ammonia can have normal cognitive functioning. What you should do instead is assess clinically for any signs of hepatic encephalopathy. So there's 4 stages that I always like to review with residents and medical students, stage 1 through 4. And so stage 1 can be as mild as a sleep-wake disturbance, which can often be one of the first signs of hepatic encephalopathy that you see. Patients are saying that they're sleeping all the time during the daytime and they're waking up at night. Their circadian rhythm is all off. These patients should already be started on lactulose. And then 2 and 3 are varying degrees of asterixis and increasing degrees of somnolence. And then stage 4 is coma. So if you have clinical suspicion for hepatic encephalopathy, treat. Do not rely on ammonia levels, and hepatic encephalopathy is a clinical diagnosis. The only indications for obtaining ammonia levels are for acute liver failure, valproate toxicity, and urea cycle disorders. I did want to touch briefly on the definition of acute liver failure because a lot of times people kind of throw this term around, patient has elevated LFTs and people will just say, patient is having liver failure. But it's very important to know the strict criteria for liver failure. And that's actually altered mental status plus an INR of greater than 1.5. So if somebody just has elevated LFTs, don't make the mistake of calling it liver failure if they're not meeting these criteria. The reason this is so important is because once somebody is defined as having liver failure, you need to consult GI or hepatology for urgent transplant evaluation. So risk of a TIPS procedure, we tend to do this for patients with severe portal hypertension and having severe complications like esophageal varices and ascites. So the major risks to be aware of with TIPS procedure is worsened hepatic encephalopathy. Remember, you're bypassing the liver, going from the portal vein to the hepatic vein, and so none of that ammonia is being processed by the liver. And then how does lactulose work? This is a very interesting question that I love asking to students. And the way it works is that it's a sugar that's digested by bacteria, and they end up acidifying the colon by releasing H+ ions. This ends up converting ammonia, which is NH3, to ammonium, which is NH4+, which is unable to be reabsorbed by the body. So then the ammonia is eliminated in the stool. Now let's move on to some high-yield topics for ED residents. So the first one I want to talk about is CO2 retention, and which VBG worries you more? A patient with a pH of 7.24 and a PCO2 of 60, or a patient with a pH of 7.24 and a PCO2 of 90? I would argue that this one is far more concerning than the one on the right, even though the PCO2 on the right is so much higher. The reason is because this is acute CO2 retention versus chronic CO2 retention. So out of all of the metabolic and respiratory compensation things that you have to remember in medical school, the one that I have really memorized is this one for compensation of respiratory acidosis. So basically, a patient with acute CO2 retention will have a drop in their pH by 0.08 for every increase in their PCO2 by 10. Whereas a patient with chronic CO2 retention will have a drop in their pH by 0.03 for every increase in their PCO2 by 10. So in this case, this patient has acute CO2 retention. They're going to need BiPAP, and they're going to need to go to the ICU if not improving. And for chronic patients with chronic CO2 retention, this is going to be your classic, usually morbidly obese patient with obesity hypoventilation syndrome and severe OSA. This is essentially their baseline. These patients can actually be managed on the floor, and there's no indication to start rescue BiPAP. Another very common board question that I always like to address is an asthmatic patient who comes in with diffuse wheezing and respiratory distress, and they're found to have a respiratory alkalosis with a low PCO2. And then treatments are started and the patient still appears tachypnic and distressed, but wheezing has gone away and repeat VBG looks potentially improved with a pH that's getting closer to normal and a PCO2 of 40, which is normal. So in this case, they always like to ask, what is the best next step in management for this patient? And in this case, the answer is to intubate the patient. This is a sign of a patient tiring out. They're no longer able to breathe as much of the PCO2 off, and they're starting to retain CO2. And the wheezing has gone away because they're now no longer moving enough air to create the wheezing noise. So this patient is actually still doing much worse and needs to be intubated for increased work of breathing. Moving on to some common questions for COPDs, I like to review the common triggers for asthma. So we have viral upper respiratory tract infections, exercise, cold, and aspirin. And then the most common trigger for COPD is going to be a viral URI, but up to 15 to 30% of these patients can be triggered from a PE. So this is a very important thing to note because we always try to identify what the trigger for the COPD exacerbation was. Was it an upper respiratory tract infection? Was it lack of adherence to medications? In the absence of any clear trigger for COPD, we probably have to start doing a little bit more digging and look for more sinister causes like a PE. Treatments for acute asthma and COPD exacerbation include duonebs, prednisone 40 times 5 days based on the REDUCE trial, azithromycin if the patient meets criteria. There's basically 3 criteria: increased dyspnea, increased sputum production, increased frequency of sputum. And if they meet 2 out of 3 of those criteria, then you should give them antibiotics. And then IV magnesium can also be beneficial because it has a bronchodilating effect. Is there any difference between IV methylprednisolone and oral prednisone? The answer is no. There's no evidence to support IV over oral prednisone. But I think in the ED setting, it totally makes sense to give IV up front. Usually we switch them to oral later in the hospital stay. But, in any concern that, the patient might not respond as well or have adequate absorption, I think the practice of doing IV methylprednisolone up front totally makes sense. And then why is the goal saturation 88 to 92%? There's a very common misconception with this question. And the most common answer is that the thought is that too much oxygen will decrease the patient's respiratory drive, but that's actually not the correct answer. The correct answer is that we maintain it at 88 to 92% to avoid reversal of hypoxic pulmonary vasculature. So basically, the lung is very smart. And if you have a patient with a COPD exacerbation, there are areas of the lung that are getting poor oxygenation and poor airflow. And the lungs will actually clamp down and vasoconstrict the vessels that are going up to those areas of poor gas exchange and instead direct more of the blood flow to the areas that do have good gas exchange. Now, if you suddenly give them tons of exogenous oxygen, up to 100%, for example, now the lung is going to think that everywhere is very well oxygenated. So those blood vessels that were initially vasoconstricted are now going to dilate and start bringing blood to areas that are still having poor gas exchange and are still being affected by severe obstruction. But the lung just can't tell because now you've fully oxygenated everything. So that can lead to worsening respiratory distress. So next, some more primary care focused questions for COPD management, seeing as the ED is responsible for a lot of kind of primary care issues for patients who may not have good follow-up otherwise. So do inhalers provide mortality benefit in COPD? The answer is no, mainly smoking cessation and supplemental oxygen, and also lung volume reduction surgery and lung transplant. These things provide some mortality benefit, but inhalers by themselves do not provide any mortality benefit. What is the order of initiating inhalers in asthma versus COPD? I learned this from an attending when I was a resident that a very easy way to remember it is ICS, LABA, and LAMA. If you're treating asthma, we go in this direction. So you start with the ICS, then you add the LABA, and then you add the LAMA. For COPD, you go in the exact opposite direction. You add the long-acting muscarinic antagonist first, then the LABA, and then the ICS. How do you know when you need to escalate therapy in asthma? This is the rule of 2s. So if a patient is using their rescue inhaler greater than 2 times a week or greater than 2 times a month for nocturnal symptoms, then you need to escalate their therapy. So for example, if they were just on an ICS, you probably need to add a LABA. And then what is the preferred rescue inhaler for COPD and asthma? The answer to this is actually an ICS-LABA combination, also known as Symbicort. Typically, you will see people on albuterol, which is just a short-acting beta agonist, but actually our updated recommendations from 2019, the Global Initiative for Asthma, recommends that our preferred reliever is as-needed low-dose ICS formoterol, whereas our other reliever option, which is the less preferred option, is the short-acting beta agonist. So as time goes on, hopefully we're going to start seeing more people on rescue Symbicort rather than rescue albuterol. Here's just some things briefly on diagnosis of asthma that probably is not super relevant for the ED setting, but asthma we diagnose with the methacholine challenge, and we're looking for a bronchodilator response on PFTs. And then for COPD, we look at the GOLD staging after confirming signs of obstruction. This is the old GOLD staging here. This is our new updated GOLD staging here with groups A, B, and E, and it kind of helps you determine what medications these patients should be on. And then what are new maintenance treatments you may see for COPD. That includes roflumilast and azithromycin. Some things that you may see in the emergency room setting. So a patient being treated for COPD exacerbation suddenly starts to have lactic acidosis. What could be the cause of this? This would be a type B lactic acidosis from albuterol. Remember, for lactic acidosis, we have type A lactic acidosis, which is from true tissue hyperperfusion, and type B lactic acidosis, which is from a variety of different causes, but beta agonists being a very common offender in this category. And another situation that may occur is a nurse suddenly coming in saying that the patient now has a fixed and dilated pupil compared to the other. This is very commonly due to ipratropium, which is a muscarinic antagonist. If it's leaking out from the nebulizer and leaking into their eye, it's going to cause a dilated pupil. So this is not really a patient that you'd be concerned for a brain herniation or something if they're mentating okay and they're just getting their COPD treatments. Let's talk about atrial fibrillation next, and we're going to start with a case. So a 65-year-old man with heart failure with EF of 35% and atrial fibrillation not on anticoagulation presents with AFib with RVR to the 140s. He is hemodynamically stable. His IVC has normal respiratory variation on POCUS, and he appears euvolemic. He has no signs of sepsis. So of the treatments that you can initiate, would you like to give him fluids? Would you like to diurese him? Give him PO digoxin, IV metoprolol, IV diltiazem, IV esmolol, IV amiodarone, or would you like to cardiovert the patient? So I'd like to include the fluids one because if the patient is fluid down, you really should start with fluids rather than just trying to upfront rate control somebody, because somebody's AFib could be compensating for their hypovolemia, for example, if they're septic. So if they're fluid down or they're fluid up, you can consider fluids and diuresis. But in this case, the patient had normal respiratory variation on his POCUS, so there's no signs that he needs fluids. For PO digoxin, this is something we do consider in patients with systolic heart failure, but this is not usually used for acute rate control. It takes several hours for onset of action, and it's something we add on when people are refractory to beta blockers and other AV nodal agents. IV metoprolol we'll discuss. IV diltiazem, we avoid this one in systolic heart failure. IV esmolol drip, there's a risk of volume overload when using this one. And then IV amiodarone, there's a risk of cardioversion, especially in a patient who's not on anticoagulation. This is something we'd be a little bit more cautious about. And then cardioversion, again, only if somebody's hemodynamically unstable would we just upfront cardiovert somebody. So in this case, the answer is going to be IV metoprolol. And so the reason I like to address this is because the diltiazem is often favored in the ED. And the reason for this is because it has a stronger AV blockade compared to IV metoprolol. So it's going to give you a better chance of determining if the patient is going to respond to rate control and then helping you figure out the disposition for this patient. So the problem is there's one situation where you do want to avoid diltiazem, and this is one of the big reasons that internists tend to use metoprolol more. It's because a lot of our patients have systolic heart failure. And so diltiazem should be avoided if patients have systolic heart failure. Again, it's a stronger inotrope compared to IV metoprolol, so there's some evidence that shows there is an increased risk for CHF exacerbation in these patients. And then what should you consider before rate controlling AFib with RVR? This is a very common question, but you should consider if patients need fluids, if patient is septic, you need to treat all of that stuff before just upfront rate controlling somebody, because there's a very high chance that somebody needs that additional cardiac output, and if you're just rate controlling them, you're going to kind of put them into a shock-like scenario if you're not treating the underlying etiology. And does PO metoprolol affect blood pressure? The answer is generally not. However, IV metoprolol does affect blood pressure, and the common question that you're going to get from nursing is, can you give IV metoprolol if the patient is hypotensive? And the answer is yes, but I would be cautious in this scenario and potentially use a lower dose. It may actually improve the patient's blood pressure if they have low cardiac output from a loss of atrial kick, which is basically when the atrium is fibrillating so much that it's not giving a good preload to the left ventricle. And when you actually rate control them a little bit more, you're going to get more of a contraction from the atrium and get a better preload to your left ventricle. Another question is, what should you give after you've achieved rate control with IV metoprolol? This is a common scenario that we see, but after you've gotten adequate rate control, you need to immediately give the patient PO metoprolol tartrate, either every Q6 hours or Q8 hours. Otherwise, the patient will jump right back into RVR. The half-life of IV metoprolol is only about 10 minutes versus 3 to 4 hours for PO. What is our goal heart rate for atrial fibrillation? This is less than 110 per the RACE 2 trial, which compared a strict rate control target of less than 80 versus less than 110, and they found improved outcomes in the lenient rate control group. And then landmark trial showing rate control equals rhythm control, but with reduced adverse events. That's going to be the AFFIRM trial. So this is why we generally prefer rate control. But there is some more recent evidence, such as the East AFNet 4 trial in 2020, which is going to start moving us more towards rhythm control in the coming years. For hypertension, another very common primary care topic that you may encounter in the emergency room. So one question that's important to address is, what are our 3 first-line antihypertensives? And that's going to be ACE, ARBs, calcium channel blockers, and thiazides based on the ALL-HAT trial. Notice how beta blockers are not included here, so patients should not be started on metoprolol for blood pressure, for example. And moving on to that, why does atenolol suck? You're going to see this. It's a very old medication. A lot of patients are still on it, but it has an increased risk for diabetes, stroke, and all-cause mortality compared to other antihypertensives. Also, it's renally cleared, which means if somebody's having an AKI, they're going to have basically a toxic buildup of atenolol. They're going to get bradycardia, and they can even develop this syndrome called the Brash syndrome, which is bradycardia, renal insufficiency, acidosis, shock, and hyperkalemia. What is the goal blood pressure for most patients? It's going to be less than 130 over 80. This was based on several trials, starting with the Accord BP trial, leading to the JNC8 guidelines. Then we had the SPRINT trial, and now we have the updated 2017 ACC AHA guidelines. Now, euglycemic DKA, this is going to be something you're going to be seeing more of in the emergency room setting. SGLT2 inhibitors are now indicated for diabetes, HFrEF, HFpEF, and CKD. So what should you do? In any patient who is on an SGLT2 inhibitor, you should have a high index of suspicion if they come in with abdominal pain, tachypnea, or other signs of DKA. So make sure you check for that anion gap on the basic metabolic panel, check a UA for ketones, and check a serum beta hydroxybutyrate. For hyponatremia, why do internists care so much about working up the etiology? And this is going to be a very bastardized, very short version that's kind of oversimplified. But in general, when there's hypovolemic hyponatremia, we treat with fluids. When patients are euvolemic, the treatment is fluid restriction. And when patients are hypervolemic, the treatment is diuresis. So if a patient's sodium drops from 126 to 120 after you gave 2 liters of normal saline, which is a very common scenario in the emergency room, do not give more fluids. This is classic for SIADH, and this patient needs to be fluid restricted. What is something useful that the ED could do to help with hospitalist workup of hyponatremia? That would be obtaining a urine sodium and urine osmolality before giving fluids. So if the patient is stable, they have asymptomatic hyponatremia, you have time. You don't have to correct it right away. If you can, it would be very helpful if you message the nurse and say, hey, can you collect these urine studies first and then give the fluids afterwards? That would be very helpful from a hospitalist perspective. And then lastly, a very common scenario, a patient comes in with a sodium of 126 and a glucose of 600. Don't forget to correct for the patient's glucose. This patient's sodium is actually 136. Immune checkpoint inhibitors. So what are immune checkpoint inhibitors? You're going to be seeing more of these as well as they make more inroads into the cancer therapy world. But these are therapies that activate the immune system to fight against tumors. For example, pembrolizumab, atezolizumab, nivolumab, etc. And what are the side effects of immune checkpoint inhibitors? So the way I like to think about this is any organ plus itis. So if somebody comes in with hypotension and hyponatremia, you can think of adrenalitis or adrenal crisis. If they come in with hypotension, hypothermia, bradycardia, and hypoglycemia, you can think of thyroiditis or myxedema coma. With shortness of breath, think pneumonitis. Chest pain plus troponins in the 3000s, think about myocarditis. AKI plus RBCs on the urinalysis, think of nephritis. And weakness and elevated CK, you can think of myositis. Altered mental status, think about cerebritis. And then diffuse rash, think about dermatitis. And then one last question I wanted to ask is that what should you do before giving levothyroxine if somebody is in myxedema coma? Well, the one thing you need to check is a cortisol level to check for adrenal insufficiency, because if you give levothyroxine in somebody who has adrenal insufficiency, you may actually precipitate an adrenal crisis. Another very common complaint that may show up in the ED is syncope, and this is from my syncope lecture. But basically, there are three major categories, and you can see reflex, which includes vasovagal syncope, is going to be the predominant cause of syncope, 65% of the time. And orthostatic hypotension is going to be causing it 15% of the time. But what you need to really do from an ED perspective is recognize cardiogenic syncope, which happens about 10% of the time and is the main dangerous etiology of syncope that we look out for. And some of the things that lead us to have a more concern for cardiogenic syncope is sudden loss of consciousness rather than having a prodrome, which you kind of have with reflex and orthostatic syncope. And having no prodrome, having exertional syncope, supine syncope, chest pain and palpitations, or increasing frequency of syncope. These are all concerning causes of syncope that warrant further workup. In terms of pulmonary embolism, this is also very commonly seen in the ED. And what you really need to know is to differentiate the three major classes of PE into non-massive, submassive, or massive, or otherwise you may hear it termed low risk, intermediate risk, or high risk. So the high risk patients, it's very clear these patients are going to go get, they're hemodynamically unstable. They're going to get TPA or embolectomy or thrombectomy. And then the non-massive patients, these are patients who have PEs, but they have no signs of right heart strain. So no elevated troponin, no BNP, none of these signs of right heart strain on POCUS. These people can actually just be started on a DOAC and just discharged from the emergency department. So even if the patient has a pretty large clot burden, multiple segments and, some segmental PEs, if they have zero signs of right heart strain, they can actually be managed as an outpatient with a DOAC. Now, if they do have signs of right heart strain, then they're going to be in this submassive or intermediate risk category. And we do further risk stratification for these patients by calculating a PESI score or a PE severity index. And if based on this, you find that they are low risk, then these patients, again, can be treated with a DOAC and discharged and managed in the outpatient setting. But if they are higher risk, you should really consult pulmonology or a PE response team that you may have at your hospital to consider some of these more interventional treatments such as, thrombectomy or thrombolysis. All right, and finally, I just wanted to conclude with some things we love about the ED. So you guys are the first line of defense for everything that comes into the hospital. Your initial workup makes a huge difference in how the patient's hospital course turns out, and often you guys are the ones making the most initial and most important diagnoses, which I think is very exciting from an ED perspective. So you guys have so much more knowledge and expertise on us on so many different topics, particularly with surgical management and time and when surgical consultation is needed. So helping get surgical consultants involved early helps us a lot, not only to determine if the patient should be triaged to a surgery service, but also to know if they're going to need some kind of operative intervention and just getting their assessment and evaluation of the patient. Thank you so much for helping us with procedures, especially lumbar punctures. It is a bit of a shame that hospitalists have kind of been losing their ability with procedures over the past many years, but LPs especially are very, very helpful for us when it's already been obtained by the ED, because otherwise for patients coming in with meningitis or something like that, they oftentimes will go multiple days without getting that LP, and then the yield of the LP becomes much lower after it's been a couple of days on antibiotics. So it really helps getting that early LP. We do appreciate when you guys have already made the decision to get imaging. So obviously, people make a lot of jokes about the ED getting a lot of imaging, but honestly, we find it very helpful when you guys have already made the decision to get imaging so that internal medicine doesn't have to sit there and pontificate whether the patient should be getting imaging or not. It's actually very helpful that, the patient was already, imaged in the ED. So never feel bad if you are getting imaging in the ED. And then one last request that we would like to make for any ED physicians or residents is that please ask patients if they want to be admitted before calling us for admission. Because many times it has happened that we get called for admission, we do a deep chart review of the patient, and then when we finally go see the patient's like, oh yeah, I'm leaving. Like I don't want to be admitted. I just wanted to like get checked up and then I want to leave. So that would be very, very helpful for us if you're able to do that. So summary, do not obtain stool guaiac for evaluation of acute upper GI bleed. Do not obtain ammonia for evaluating hepatic encephalopathy. Recognize acute versus chronic CO2 retention. No benign causes of lactic acidosis and dilated pupil for COPD therapy. Avoid diltiazem in systolic heart failure. Assess if a patient's atrial fibrillation is compensatory and may need fluids before just trying to rate control it. Atenolol sucks, and also you will be seeing more euglycemic DKA. Get urine studies for hyponatremia if you can. Don't keep giving fluids if the sodium is worsening. Know the side effects of immune checkpoint inhibitors. Recognize concerning features of syncope and understand the different categories of PE and calculating the PE severity index. Here is my YouTube channel, which you guys, if you're watching here, you're already watching on the YouTube channel. But I have a whole playlist on residency guides and EMR guides, and videos that I think would be helpful for ED residents or ED physicians. Would be things like CPAP, VT, ventilators, COPD and asthma, pressors and sedation. And then I have guides on atrial fibrillation, acute coronary syndrome, heart failure, and hypertensive emergency. So if you have time and you're interested, definitely feel free to check those out. I hope this video was useful just as a broad overview of internal medicine's perspectives on, things that are done in the ED and things that we appreciate that you guys do. So thank you guys so much for watching. Please let me know down in the comments below if this was helpful and if you have any questions. Thanks again for watching, and I'll see you in the next one.